Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with my favorite ICU doc. How you doing, Doug?
I'm great, Dennis. How are you?
I'm doing well. Today I have a really nerdy question for you. So the reason I got you on, Doug, is this is, I think, it could be a very in-depth question, and I know that you're very used to that type of material. What I really need to know about is sodium bicarb, and specifically when it has to do with crush type syndromes, metabolic acidosis type syndromes, because I think it's getting kind of overhyped or oversold as kind of like the miracle thing that's going to fix all of your problems.
I think that's a misconception. I know that bicarbonate is in many different crush protocols, but it's also not in many different crush protocols. Most specifically, the one we wrote for the Prolonged Field Care Working Group, the clinical practice guideline that we published a few years ago, where we kind of talked about there are, some theoretical benefits to using bicarbonate, but none has shown to be of clinical benefit in patients, really in any clinical trial. That all the benefits are in the bench or using lab animals, which just aren't real world conditions.
So, how would they really show benefit when you're giving lots of fluids? There's lots of things going on to confound it. How would they show benefit?
Right. Well, the two big risks in rhabdomyolysis, which is, can be traumatic. So rhabdomyolysis is the breakdown of skeletal muscle causing the release of myoglobin, which is a material contained in skeletal muscle that can clog up the tubules in the kidney and cause basically like a hydrostatic renal failure. But the tubules get plugged, fluid doesn't flow, and backs up and causes the kidney to fail. And the other big thing that we're worried about is the accumulation of toxic metabolites from inside the crushed cells or the destroyed cells. And the most concerning of those is potassium, which is a cardiotoxin. So in high enough doses, potassium will cause a lethal arrhythmia, ventricular tachycardia, ventricular fibrillation, and can kill you from cardiac arrest. So your endpoints with treating any rhabdomyolysis, whether traumatic or caused by a heat injury or drug overdose or malignant hyperthermia or diabetic ketoacidosis, the cause of the rhabdomyolysis doesn't really matter. The endpoint is the same. You want to prevent kidney damage from the accumulation of myoglobin, and you want to reduce the risk of cardiac arrest from hyperkalemia, from high potassium. And really the first, second, and third mechanism of therapy is to flush the tubules out with high rates of intravenous fluid, classically normal saline, but in a austere environment, whatever IV fluid you have is fine, and try to aim for a urine output of 200 cc's an hour minimum.
Okay. It's going to take a hot minute to get that started, not the IV in the fluids, but to get the urine output that high. How early do you want to start this?
Right away.
Okay.
If you suspect rhabdomyolysis from any source, you see tea-colored urine in a guy who's just done a 3-hour CrossFit workout, and dehydrated himself because he thought that was going to help him, do the workout better and get better results. If you see, obvious crush, somebody's entrapped in a vehicle for a long time and extricated. Somebody, we see it in hospital medicine in patients who have cardiac arrest and are found at home after a period of immobility, which can be as short as an hour or two. Just being down immobile on large muscle groups like the glutes and the thigh muscles is enough to cause rhabdo. As soon as you suspect it, start your fluids. You're not really going to hurt them by starting too early, but you can, potentially increase their risk of either acute kidney injury or permanent kidney injury if you wait too long. This is one of those where it's better to shoot first, aim later. I don't say that often in medicine, but this is one of those ones where you need to ready, fire, aim, because if you then do a dipstick and you don't see myoglobin, the urine clears, you can always stop it. But if you wait too long, the kidneys may just shut down, and then you're in a world of hurt.
Right. I think I would imagine it's probably a lot like you suspect herniation is starting with a TBI, severe TBI, and you send your hypertonic.
Right. Exactly right. Because one dose of hypertonic is not going to cause any serious side effects, if any side effects at all. Whereas delaying it, could result in a catastrophic neurologic injury. 100% correct.
Yeah. Perfect. So, we get this guy hooked up with IV fluids. We start sending it. Obviously, you have your calcium on standby. You're watching your monitors, and we talk about like the insulin and D50. We talk about the albuterol to hide the potassium, but inevitably, bicarbonate gets whipped out because I don't know. This is like the big boy drug when it comes to crush, and we set it up. They push the 1 amp, so 50 milliequivalents, and usually they look at me and I tell them, hey, your end tidal CO2 goes up, and then a little while later it's come back down, and nothing's really happened. Obviously, that's just a training scenario, but if there was a thing that it was doing, I guess how do we use it effectively, or know who to use it effectively on? Because the idea that I'm going to really change his pH that much, I guess I don't believe it.
Right. Well, first off, most of the studies look at alkalizing the urine to a specific pH, which you're going to need to measure. I suppose with a dipstick, will give you a range, but you're going to need to get the pH like 6.5 or so. And if you're not objectively measuring it, then you really don't know how much bicarb to push, and you really don't know how frequently to measure. So it's fairly labor intensive. It's also fairly resource intensive because you're burning dipstick, test strips, and you're burning your bicarb, which I'm sure you don't have an infinite supply of. And and again, for no proven benefit, you'd be better off focusing on your urine output and what you can do to increase that.
Yeah. So, I mean, I believe like 90% of the potassium ends up coming through the urine anyway. Mm-hmm. So it makes a lot of sense to focus on urine output. Mm-hmm. If fluids alone are not doing it, what else can I do safely?
Well, there's sort of two mechanisms of managing acute hyperkalemia, high potassium. You can drive it back into the cells, and the medicines that will do that will be insulin. Insulin causes potassium to be reabsorbed by the cells. However, you have to give a decent dose of insulin, like 10 units of insulin, which in a normal non-diabetic person is probably going to make them profoundly hypoglycemic. So you give it with a D50. The D50 doesn't do anything therapeutically except keep you from crashing from, hypoglycemia when you give the insulin. And then albuterol, but you really need a lot of albuterol. We typically talk about a 20-minute, a 20-minute dose of nebulized albuterol, which is, absorbed into the pulmonary capillary, is probably a little bit better than metered dose inhaler albuterol.
Can you go metered dose inhalers? Every people usually quote puffs, right?
Mm-hmm.
I haven't really found anything that's reliable to say this many puffs equals X number of milliliters.
Right.
Nebulized stuff. I mean, you're talking like one canister of it, or?
No, I mean, we're giving, 3 canisters of nebulized stuff. So I would think you would need that much MDI. The problem with the metered dose inhaler is most of it winds up in your mouth. Even with this, even with a spacer, which you're probably not going to have. So I'm not sure I probably wouldn't even worry about giving an MDI. You don't have that many of them. Save them for the patients with respiratory problems who are really going to need them. I think the thing to consider carrying for crush, and we've talked about this since the CPG is written, is one of the mechanisms. So that's the first mechanism, right? Is to drive it back into the cell. The second mechanism is to get rid of the potassium, right? To excrete it from the body, and that can be done in several ways. You can bind it up in the stool with capsuling and put it on, but that's going to take hours and hours, like 6 hours. You can, the fastest way to do it is to increase potassium filtration through the kidneys using a lift diuretic. So LASIK is so if it were me, and we do this in the hospital all the time. If we're treating acute hyperkalemia and trying to avoid putting somebody on dialysis, giving them a chance of medical therapy, part of the cocktail is going to be 40 milligrams of isolation. And that's easy to carry, it's stable, demonstrably lowers potassium. And it will increase your urine flow, which is going to help your name.
Right. So, how bad of a patient would you be willing to use that on?
Let's say we don't have that. So I would use that in the patient where I'm seeing PVCs or runs of VT on my telemetry. If I have telemetry, hopefully I do, where if I'm feeling PVCs or if the patient complains of palpitation. And that's a super important question to be asking the patient. Like, do you feel chesty? Do you feel palpitation? Do you feel heart racing in your chest? And then you'll feel their pulse, feel for PVC. If you can, like even a 3-lead, some sort of telemetry, and be looking for, increasing frequency of PVC, short runs of VT, then like the person I would, give them some calcium to stabilize their myocytes and electrical conductive system, and a loop diuretic. And then the third mechanism for removing something that's not available in long-term, which is to dial.
Okay. Well, I mean, you have needle dialysis.
Yeah, if you can set up the needle dialysis, that would be your last step for sure. If you're hyperkalemic, you're getting PVCs, you're getting runs of VT, you're getting palpitation, you get LASIK, and that is probably in some sort of renal failure in your kidney system responding to the fluid in the LASIK condition.
Right.
Either because you're too late initiating therapy, or in a certain state was so great that the kidneys didn't have a chance.
Right. That 40 milligrams of LASIK, how long would you expect that to last? Keeping that
About 6 hours.
6 hours?
Yeah.
Okay.
Yeah.
So that's going to be a lot of fluid you're putting in as well. I would definitely probably suggest putting an IV line. Right?
Yeah.
Multiple sources of access. Hopefully they're just enough to drink.
Yeah. Yeah, I mean, if they can drink, it doesn't really matter whether they're getting fluid. What really matters is the flow through the kidneys. In most resuscitations, we talk about 30 to 50 cc's an hour, or 0.5 cc's per kilogram, is being inadequate urine output. This is different. This is good enough, or barely good enough kidney performance. This is really aimed at hydrostatic pressure and flow to dislodge the myoglobin, which is very sticky. So you really need to turn your faucet on high to dislodge it, otherwise it's going to get stuck and precipitate and worsen your renal failure.
Right. Would you say, let's say I'm in a situation, we have the crush patient we just talked about, who was throwing PVCs, and I put the calcium on, we got fluids going, we have like multiple lines of access. I push the Lasix, so my urine output is, 200 plus. Would it be safe, and I have no lab, so I have no ability to find out what the potassium actually is. If Lasix lasts roughly 6 hours, right, I start to see that urine output start to come down, so I'm expecting, okay, the Lasix is coming off, but I'm not finding any arrhythmias of any kind, like the PVCs have stopped, the runs of ETAC have stopped, etc., etc. Would I be safe to stop with the Lasix and just continue fluids until, I have some other indicator that I can go ahead and stop with this as well?
Yeah, absolutely. And you want to be cautious with the Lasix. Obviously, don't shy away from it if you think it's indicated. But if it's not indicated, then you're right. I would stop because hypokalemia, low potassium, can also trigger serious arrhythmias. So, you want that potassium in a sweet spot between 3 and 4, milliequivalents per liter. And you're not going to be able to measure that. So, over 6, less than 2.5, you're going to be in trouble. So you're just going to have to dial it into your clinical signs. And if those are gone, I wouldn't redose them. I'd wait until they come back. And chances are probably pretty low that they are coming back because, you're going to clear the potassium from rhabdomyolysis faster than you clear the myoglobin.
Oh, okay. Perfect. And then you start getting your output clear up, and then you can kind of start dialing back, I would imagine.
Yeah, your creatine phosphokinase, which is another lab that we measure in rhabdomyolysis, that's going to continue to rise, potentially for half a day or a day. But once you get good urine output, your potassium levels should fall after you switch. Unless you go into renal failure, unless you can't improve your output.
Right, definitely makes sense.
Yeah.
So what about, because one of the things they talk about with certain bicarb is by alkalinizing the urine, which we may or may not be able to do, you are preventing the clot formation, and you're preventing the acute kidney injury from happening. Is that a real effect, or is that just theoretical?
Well, it may be an effect, but by alkalizing your urine, in the human trials that have been done, none of which are great quality, like lots of case series and retrospective analysis, very few randomized placebo-controlled trials. There's really no difference in the bicarbonate arm and the IV fluids arm in terms of progression to acute kidney injury. There's one paper that showed a difference, and everybody else was no difference. So, like I said, it may actually do that, but whether it's clinically significant is probably is not.
Right. So I think the study that I sent you, it said that alkaline above, I think it was like 6.3 or 6.5, something like that.
Yeah.
Like that's still really bad. Like that's very acidic.
The urine is always more acidic.
Right.
So there's that.
But that's very true. I don't know, to be honest, without Fresh, and an improvised, I guess, hypertonic for severe TBI? Like why would we take Bicarb?
Yeah, Bicarb will make you a improvised hypertonic solution, which is great. And like I said, the main reason I think to manipulate anybody's pH is if you have a metabolic acidosis that's causing clinical harm, right? Your heart isn't squeezing as well, your blood vessels aren't squeezing as well, and your coagulopathic, and or you're so acidic that you're resistant to catecholamine pressors and trauma. So, I think we talked about it we may have talked about it in the last podcast we did, but, pH are less than 7.25, you're going to become coagulopathic. Your clotting factors are losing 30% of their effectiveness. And it goes quick from there. Below 7.2, it's like 50%. And if it is below 7.15, you're resistant to the pressure effects of epinephrine and phenylephrine. So the only things that will work would be vasopressin and some exotic pressors that you're not going to have access to. And with pH, in the 7.1s and below, your cardiac contractility is going to be down, as well as your vascular tone. So you're going to have a vasodilatory shock and cardiogenic shock just because of what cardiac output. So in those extreme situations, you have correcting pH correcting acidosis to a pH of 7.25 is not a bad thing in somebody who's either coagulopathic or in shock. Especially shock that's resistant to pressure. You're having to dial up your epinephrine, you're having to add a second pressor, and a third pressor. Then you really need to think about normalizing the pH. Not normalizing, improving the pH.
Right. How much movement can you get? I mean, obviously, it varies, but with an amp of bicarb, an adult-sized human being, how much movement of the pH can I get out of that 1 amp?
Let me think and give you the simple answer first, and then I'll give you the complex answer. The simple answer is we're going to get probably hundreds, maybe 300 or 400. And I'm obviously totally anecdotal. If somebody looks it up and says, "Hey, you're wrong," I'd be happy to admit that I'm wrong. But I generally think if I've got a pH of 7.1, I'll normally give 3 amps of bicarb to get to a pH of 7.25, 7.27. So maybe that's what 0.05 of an increase per amp. Now that is in person, so that's the simple answer. That's a simple answer. The complex answer is there. You could give an amp and you could come up with a bit more. In general, not. I think 0.05 is probably the bigger likelihood is a worse situation where they are in decompensated shock that is progressing to irreversible shock, and their acidosis is a sign of that. And in those patients, you pour bicarb into them, and there's no change. You put in a dozen amps, and we've done this, over the course of 2 or 3 hours or more resuscitation. You put in a dozen amps or more, and their foods either go sideways or it's even worse. That's because their shock is progressing from decompensated to irreversible. Either because of the dose of the shock, the magnitude of the initial insult, the amount of blood loss, how much muscle was damaged in the how bad their sepsis is, or because of the delay in presentation or delay in the treatment that the shock train just got in the rails and gathered so much speed that you can't slow it down.
Right. No, that definitely makes a lot of sense. I mean, obviously it's going to be difficult for us to monitor that in the field, maybe in a clinic, maybe, you get a nice bath and you happen to be the one who's got yours updated and you have the cartridges and stuff like that. But, am I using like an insulin syringe to get this, or do I need like a case of it to do anything? You know what I mean?
Right.
Right. I would imagine in that situation, like you're talking about, he's not responding to blood. He's not responding to calcium. They're not, he's not responding how they normally should. Maybe it's worth throwing some bicarb at him.
Yeah. Yeah. Exactly right. They're not. You can't get them warm. There are other signs of a patient who's in severely decompensated shock, bordering on irreversible, or frankly irreversible shock. And the definition of irreversible shock is they don't get better no matter what you do, or they continue to get worse no matter what you do. And you've got all sorts of clinical markers for them not getting better. Their blood pressure goes down, and their temperature gets colder no matter how much you try to warm them. pH is just one thing, but you don't need pH to know that your patient is not responding to aggressive therapy.
Right. And I mean, the risk of cloud, I'm guessing is really small, right? But don't do that.
Right.
Alkalosis doesn't seem so bad.
Yeah. Now, if you have that patient, then I realize we've kind of gone down and played a little bit of a tangent here, but hopefully listeners will indulge us. If you have that patient who you really suspect is progressing toward irreversible shock, don't give them, don't give them a homeopathic dose of bicarb. Don't give them one. Give them 3. Give them 3. Again, you're not going to harm them with acidosis. You're not going to harm them with the respiratory acidosis when it breaks down to carbon dioxide. You give them 10 amps, you'll cause a respiratory acidosis. You give them 3, they won't. But 3 is a reasonable testing. And if they get better, well, maybe they have an acidosis, and maybe they are irreversible. Maybe they are responsive to therapy. So, maybe I should continue doing this. So, you can also make the bicarbonate infusion. You can put 3 into bicarbonate in standing. Once you've given them 3 bolus doses, you can do that and run 25 or 50 cc an hour. Just not enough clinical background of back in the kitchen. So, again, we were way off topic for crash. This is talking about minimal acidosis and shock. But, to circle back in talking about crash, is that your job is to get enough filling in the end that you can plus or minus the diamond that you can get 260 an hour of kidneys. And if you can't do that, then you need to do some sort of analysis potentially.
No, really, all I was looking for is just a real in-depth explanation. Sodium bicarb, obviously we're talking about it before, but there are definitely places for it. So let's save what little supply we have for those instances that it may actually work.
Yeah, couldn't agree more.
Cool. Well, thank you very much, Doug.
Dennis, always a pleasure, and looking forward to the next conversation, the next topic that you or the listeners come up with. Happy to help anytime.
I appreciate it. I'll dream something up.
Okay, have a good one.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.